Welcome back to Rad Onc Smart Review GU Cancer Series. Today we are covering episode 27, Case-Based Review RCC Mock Oral, Solitary Kidney IVC, and Oligoprogression.
Right, and just to set the stage for everyone, I'm really looking forward to this one.
Yeah, absolutely. So to the listener tuning in, this is a true mock oral board session. I will be serving as your examiner today, and we have our resident examinee right here on the hot seat.
Yep, the hot seat's definitely the right word for it.
I strongly instruct you, the listener, to pause the audio after I ask each question. Build your own structured answer out loud, in your living room or your car before you listen to the model response provided today.
Honestly, it's the best way to practice. You have to hear yourself say it out loud.
Exactly. Renal Cell Carcinoma, or RCC, oral boards strictly test your clinical judgment. You really have to know exactly when to use radiation, when surgery is the absolute unshakable standard, and when metastasis-directed local therapy can preserve a systemic regimen without overselling what the actual data can prove. So, are you ready for the first case?
I am ready. Let me just organize my thoughts a bit, and yeah, let's get started.
All right, block 1. Medically inoperable primary RCC in a solitary kidney. Here is your initial presentation. You are seeing a 75-year-old man referred to your clinic from urology. He has severe COPD and relies on home oxygen.
Okay, severe COPD. Got it.
Right. His ECOG performance status is 2. 8 years ago, he underwent a left radical nephrectomy for a PT1B clear cell RCC.
So he's got a solitary right kidney now?
Precisely. And now, his routine surveillance imaging shows a new 4.5 centimeter enhancing mass in the midpole of his solitary right kidney.
Okay, 4.5 centimeters.
Yep. A core needle biopsy has been performed, and it confirms clear cell RCC. His baseline eGFR is 42 milliliters per minute.
Right, so his renal function is already fairly compromised.
Exactly. Urology, anesthesia, and surgical oncology have all reviewed his case, and they agree he is absolutely not a candidate for a partial nephrectomy due to his severe lack of pulmonary reserve. Furthermore, performing a radical nephrectomy on his solitary kidney would, mandate permanent hemodialysis. You review his CT of the chest, abdomen, and pelvis, which reveals no distant metastases and no pathologic adenopathy.
Okay, so localized disease.
Correct. The tumor is exophytic, and it sits approximately 1.5 centimeters from adjacent small bowel loops. So, doctor, how do you complete the workup and frame the key decision points for this patient?
Great, okay. Let me organize my answer. The patient presents with a biopsy-proven CT1B clear cell RCC in a solitary kidney. Because he is medically inoperable, the curative intent non-surgical options I would consider are thermal ablation and SBRT.
Yeah.
Evaluating his workup, the ascendant components are largely complete. We have histologic confirmation, we have cross-sectional staging ruling out metastatic disease, and we've established his baseline renal function with an eGFR of 42 milliliters per minute.
Right. So what's next?
Well, moving forward, the next step is to carefully review the CT and MRI images, specifically to assess the geometry of the tumor in relation to the small bowel, because that 1.5 centimeter distance is a really critical planning parameter.
Very critical.
Yeah. Additionally, I need to plan for motion management right up front. Given his severe COPD and reliance on home oxygen, I must assume he cannot hold his breath reliably. Therefore, I will plan for a free-breathing 4D CT for simulation.
Let me just stop you right there and probe a bit deeper on that.
Yeah.
You specifically noted his severe COPD.
Yeah.
And chose a free-breathing 4D CT.
Right.
In a lot of our abdominal SBRT cases, we heavily prefer active breath hold techniques to minimize the target motion. Why are you specifically abandoning a breath hold technique for this patient? Like, what is the physiological limitation you're anticipating?
That is a crucial distinction. In a young, healthy patient, an active breath hold technique like deep inspiration breath hold is fantastic because it effectively freezes the kidney in place, allowing for a much smaller planning target volume. However, this specific patient is a 75-year-old man with an ECOG performance status of 2 and severe COPD requiring home oxygen. His pulmonary reserve is completely depleted.
Right.
A breath hold technique requires the patient to take a deep, reproducible breath and hold it perfectly still for, up to 20 or 30 seconds at a time, multiple times throughout the treatment session.
And you don't think you can do that?
No, a patient with severe COPD physically cannot achieve that reproducibility. If he gasps or exhales during the radiation delivery because he's starved for oxygen, the tumor moves out of the radiation field, and we end up delivering an ablative dose directly into his healthy remaining kidney tissue, or worse, his adjacent bowel.
Very true.
So a free-breathing 4D CT allows us to map the full trajectory of the tumor while he breathes comfortably, ensuring we do not compromise his safety for the sake of a smaller target margin.
That is exactly the clinical judgment I'm looking for. You are adapting the technology to the patient's physiology, not the other way around. Now, I want to circle back to another detail you mentioned. You noted that the biopsy confirmed clear cell RCC. I want to highlight a crucial teaching pearl for our listeners here.
Okay.
In lung cancer, we sometimes treat empirically with SBRT without a biopsy if the procedural risk is too high. Why is that core needle biopsy absolutely mandatory for curative intent non-surgical kidney treatment?
Right. The biopsy is mandatory because not all enhancing renal masses are malignant. A significant percentage of small to medium renal masses end up being benign entities, such as oncocytomas or lipid core angiomyolipomas.
Exactly.
If we perform a radical nephrectomy and the pathology comes back benign, the patient has lost a kidney, but they are otherwise fine. However, in this scenario, the patient only has one kidney left and his eGFR is already severely compromised at 42 milliliters per minute.
Right, he's barely hanging on.
Right. If we deliver ablative radiation to a solitary kidney for a benign tumor, we are permanently destroying functional nephrons and risking throwing him into end-stage renal disease for a tumor that never posed a threat to his life in the first place. Biopsy confirmation is the ultimate safeguard against that tragic outcome.
Precisely. Never ablate a solitary kidney without absolute histologic proof of malignancy when it is technically feasible to get a biopsy.
Absolutely.
Okay, moving to staging, treatment selection, and evidence. You have confirmed a CT1B N0M0 clear cell RCC in a solitary kidney with an eGFR of 42 milliliters per minute.
Right.
What is your preferred treatment strategy, and what is the specific evidence you would cite to support it?
My preferred treatment strategy is definitive SBRT to the right renal mass. The strongest prospective dataset supporting this approach is the FAST-TRACK 2 trial.
Tell me about that.
This was a beautifully designed prospective study that risk-stratified patients strictly by tumor size. For tumors that were 4 centimeters or smaller, they utilized 26 grays in 1 fraction. For tumors larger than 4 to 10 centimeters, they prescribed 42 gray in 3 fractions. The trial demonstrated excellent local control, strong freedom from distant failure, and a highly acceptable toxicity profile in a specifically medically inoperable population.
Any other data?
Yeah, to supplement that prospective data, I would also cite the IROCK consortium data for long-term safety and efficacy. IRCK is a large, pooled, international retrospective dataset showing that primary RCC seb-ER remains effective and safe over many years of follow-up.
Let us dig into the FAST-TRACK 2 dosing, because this is where the board examiners will really test your understanding of radiobiology.
Okay.
The trial used 2 very different fractionations, 26 gray in 1 fraction and 42 grays in 3 fractions. Why did the trial designers draw the line at 4 centimeters? Like, what happens biologically and anatomically when a tumor crosses that 4 centimeter threshold?
The 4 centimeter cutoff is deeply rooted in tumor radiobiology and basic anatomy. Tumors 4 centimeters or smaller are generally well oxygenated throughout and have less central necrosis. A single massive dose of 26 gray is highly effective at destroying these smaller lesions.
Right.
However, once a tumor grows larger than 4 to 10 centimeters, a couple of things happen. First, the core of the tumor becomes hypoxic, meaning it lacks oxygen, making it significantly more resistant to radiation. You need a higher total biological dose to kill it.
And the second thing?
Second, a tumor that large takes up vastly more physical space, meaning it is much more likely to be pressing directly against critical organs like the small bowel. Delivering 26 grays in a single fraction to a large tumor touching the bowel is virtually guaranteed to cause severe late toxicity.
So how does the 3-fraction regimen solve that?
By using 42 gray in 3 fractions, we achieve the massive biological equivalent dose needed to overcome the hypoxia in the large tumor, but we actively exploit the radiobiological principle of fractionation. The 48 hours between those 3 fractions allows the healthy, rapidly dividing epithelial cells of the adjacent bowel to repair their sublethal DNA damage, sparing them from late toxicity.
I am going to push back on you here, doctor. You just laid out a compelling case for the radiobiology's SBRT. But on boards, you have to acknowledge the standard of care.
Right.
Earlier, in your mental framework, you likely considered surgery. If this man's tumor is a massive 4.5 centimeters and is sitting a mere 1.5 centimeters from his bowel, aren't you terrified of radiation toxicity?
Well, I would say terrified, but
Why not just bite the bullet, recommend a radical nephrectomy, and let him go on dialysis? I mean, hemodialysis is not a death sentence. People live on dialysis for years.
On boards, I would say it this way. I must carefully frame that CBR has not been proven to be oncologically equal to surgery in a randomized fashion. Surgery remains the gold standard for operable patients.
Okay, good.
However, the key decision point here is that this patient is medically inoperable. Recommending a radical nephrectomy for a 75-year-old with severe COPD, an ECOG performance status of 2, and reliance on home oxygen is essentially recommending a procedure he might not survive.
Fair point.
Furthermore, while dialysis is a life-sustaining treatment, initiating permanent hemodialysis in an elderly patient with severe cardiopulmonary comorbidities carries a massive mortality rate within the first year, not to mention a catastrophic decline in his quality of life.
That's true.
My choice of 42 gray in 3 fractions is specifically tailored to balance these risks. Because his tumor is 4.5 centimeters, and because it is situated only 1.5 centimeters from the small bowel, the 3-fraction regimen allows me to safely deliver an ablative dose while respecting the hollow viscous constraints of the bowel, preserving both his life and his remaining kidney function.
Excellent defense. And that is exactly the teaching pearl for our listeners. In primary kidney SABR, it is the combination of tumor size and bowel geometry that strictly drives your fractionation. Because of the size and the bowel proximity, 42 grays in 3 fractions is the absolute most defensible board answer here. So you have committed to 42 grays in 3 fractions. Walk me through your simulation, your target volumes, and your organ at risk priorities in the clinic.
For simulation, I would position the patient supine with his arms up, immobilized in a custom vacuum cushion.
Why the vacuum cushion?
The vacuum cushion is vital because it molds to his exact body contours, ensuring daily reproducibility when we set him up on the treatment table.
Right, makes sense.
I would acquire a 4D CT scan to accurately capture and quantify the superior-inferior excursion of the kidney during his free-breathing respiratory cycle. To aid in precise target delineation, I would fuse a multiparametric MRI as well as a diagnostic arterial phase contrast CT, co-registering these to the non-contrast simulation CT.
Hold on. Why fuse the MRI and the arterial phase CT? Doesn't the 4D CT give you enough of a picture to see a 4.5 centimeter mass?
Well, the non-contrast 4D CT shows us the motion, but it is terrible for soft tissue definition. A clear cell RCC and the normal healthy renal cortex can look almost identical in terms of density on a non-contrast scan.
That's true.
The arterial phase CT is critical because clear cell RCC is a highly vascular tumor. It lights up brightly during the arterial phase of contrast injection, allowing us to see the exact border between the tumor and the healthy kidney tissue.
And the MRI?
The MRI, particularly the T1 post-contrast sequences, provides unparalleled soft tissue resolution, which is essential for ensuring the tumor is not subtly invading the renal vein or the collecting system.
That is a great explanation of the imaging mechanics. Continue with your volumes.
Thank you. For my volumes, the gross tumor volume, or GTV, is the enhancing tumor seen on those fused MRI and CT images. My internal target volume, or ITV, will encompass the entire trajectory of the GTV across all respiratory slices generated by the 4D CT.
Okay. And
Finally, I will add a small isotropic margin, typically around 3 to 5 millimeters, depending on our daily cone beam CT image guidance protocols, to create the planning target volume, or PTV. There is strictly no elective nodal irradiation in this setting.
Good. And what about your organs at risk? How do you prioritize them?
The primary OARs are the uninvolved ipsilateral kidney, the adjacent small bowel, the duodenum, the stomach, the liver, and the spinal canal.
Okay. Standard abdominal structures.
Right. But the crucial technique here, the absolute defining factor in planning a solitary kidney case, is how you contour the kidney itself. I will specifically contour the uninvolved ipsilateral renal cortex, and then I will perform a Boolean subtraction of the ITV.
Boolean subtraction. Let's get into that.
Yes. This gives me a structure of purely functional, non-targeted renal tissue. My planning priority is to strictly limit any high-dose spill into this functional cortex, minimizing the volume receiving low and intermediate doses while maintaining ablative coverage of the PTV. Concurrently, because we are using a 3-fraction regimen, I will enforce hard maximum dose constraints for the adjacent small bowel to prevent ulceration or perforation.
I want to focus on that Boolean subtraction because that is a fantastic board-level concept.
It really is.
For our listeners trying to visualize this, how does Boolean subtraction actually work in the planning software, and why is it so vital?
Right, so for our listeners, Boolean subtraction is exactly like using a cookie cutter. Imagine you roll out a sheet of dough that represents the entire volume of the remaining right kidney.
Okay, I'm with you.
Then you take a cookie cutter representing the internal target volume, or ITV, and you press it right into the middle of that dough. When you pull the cookie cutter away, the dough that is left behind represents the purely functional, healthy renal tissue.
That's a great visual.
By doing this in the software, we create a specific, distinct structure that the computer optimizer can recognize. We tell the treatment planning computer to strictly evaluate the dose only to that remaining dough, forcing the algorithms to bend the radiation dose away from the healthy nephrons.
Perfect. That brings us to our next critical teaching pearl. Protecting a solitary kidney is not simply about dropping a magic one-line dose constraint number into your optimizer and walking away.
Exactly.
It is about a rigorous, intentional contouring of the uninvolved kidney outside the ITV using Boolean logic and actively steering the high-dose lines away from the remaining nephrons. Let us move to outcomes, counseling, and follow-up.
All right.
The patient is sitting across from you. He is anxious. He asks you directly, "Doctor, what are the chances this actually cures my cancer, and will I end up on a dialysis machine?"
I appreciate that he is asking the hard questions, and I would counsel him honestly and directly. First, I would confidently state that the chance of local control is excellent.
What kind of numbers are we talking about?
Based on the Fast Track 2 and IROS-seq data, we see local control rates consistently exceeding 90% at the treated site. It's a highly ablative, effective treatment.
Okay. And the dialysis question.
However, regarding his renal function, I would counsel him that his kidney function will likely drop moderately over the next year or two. A decline in eGFR is an expected side effect of irradiating a portion of his solitary kidney. I would explicitly tell him that while the risk of requiring permanent dialysis is low and uncommon, because this is his only kidney, the risk is absolutely not zero. He needs to make his decision understanding that small but real risk.
Okay, but let's say the patient presses you. He says, "Doctor, what is the actual mechanism? Is the radiation going to burn my kidney instantly?" How do you explain the timeline and the physiology of this decline to a layman?
I would explain that the radiation does not destroy the kidney instantly. The damage happens slowly over many months, sometimes years. The radiation primarily affects the microvasculature, the tiny blood vessels inside the kidney that help filter the blood. As the tiny vessels become scarred and narrowed from the radiation exposure, the surviving nephrons lose their blood supply and eventually scar down as well, a process known as glomerulosclerosis.
Right.
Because this is a chronic progressive process, the drop in his eGFR will be gradual, which is why we must monitor it closely.
That is a very empathetic and scientifically accurate way to counsel the patient. So what is your follow-up plan?
For follow-up, I would explain that we will monitor his renal function with serial creatinine and eGFR blood tests. We will also perform contrast imaging, either CT or MRI, every 3 to 6 months. Most importantly, I would heavily warn him against allowing anyone to perform a short-interval biopsy of the treated area.
Why? Let's play this out. He gets a scan at 6 months, and the radiologist reads it as persistent enhancement, suspicious for residual disease. The urologist calls you and says they want to biopsy it to see if the radiation failed. Do you let them?
Absolutely not. I would explain to the urologist and the patient that post-SBRT tumors often exhibit a phenomenon called pseudoprogression.
Yes, pseudoprogression.
The high doses of radiation cause intense, localized inflammation and vascular changes that can mimic a growing or active tumor on a CT scan. The tumor may continue to show contrast enhancement and may change very slowly over a long period of time.
Exactly.
Sustained enhancement or a lack of immediate shrinkage does not mean the treatment failed. A premature biopsy into that highly inflamed necrotic tissue can cause severe, unnecessary complications, including non-healing fistulas or massive bleeding. We must rely on long-term serial imaging to confirm stability.
Excellent bedside manner and clinical foresight.
Yeah.
The teaching pearl here validates exactly what you just said. Local control is high, renal decline is usually moderate, and the dialysis risk is definitively low, but you must explicitly state to the patient that it is non-zero. And never biopsy a post-SBRT kidney mass purely for persistent enhancement.
Right, just don't do it.
Now, let us introduce a subcase twist to see how you pivot. I'm giving you a new patient entirely.
Already.
A 62-year-old, otherwise very healthy man. He presents with a large 9-centimeter right clear cell RCC. Imaging reveals a Mayo level 2 IVC thrombus. There are absolutely no distant metastases.
Okay, no distant MITs.
Right. Urology is consulting you, asking about the role of neoadjuvant or adjuvant radiation therapy for the primary site and the thrombus. And they also want your thoughts on adjuvant systemic therapy. How do you manage this?
Well, I immediately recognize this as a surgical case, not a primary radiation case. The key decision point is correctly identifying the anatomical extent of the tumor thrombus.
Walk me through that.
Let me organize my answer by defining the Mayo levels, as this fundamentally dictates the surgical planning and the risk to the patient. A Mayo level I thrombus extends less than 2 centimeters into the inferior vena cava above the renal vein.
Right.
A Mayo level 2 thrombus extends more than 2 centimeters above the renal vein but remains below the hepatic veins. A Mayo level 3 thrombus extends above the hepatic veins but remains below the diaphragm. Finally, a Mayo level 4 thrombus extends above the diaphragm and can reach directly into the right atrium of the heart.
That is a textbook anatomical breakdown. Let me ask you, what is the physiological significance of the hepatic veins in this classification? Why is the jump from a level 2 to a level 3 so treacherous for the surgeons?
The hepatic veins are critical because they drain the massive blood volume of the liver directly into the inferior vena cava just below the diaphragm.
Right.
If a tumor thrombus extends above the hepatic veins, which is a Mayo level 3, the surgical team has a monumental task. They have to gain vascular control of the IVC above that thrombus to prevent a piece of the tumor from breaking off and causing a fatal pulmonary embolism during the extraction.
Which is incredibly complex.
Exactly. Gaining that control often requires fully mobilizing the liver, and depending on the height of the thrombus, it sometimes even requires putting the patient on cardiopulmonary bypass to safely open the vena cava.
And for our patient.
Because this patient has a level 2 thrombus, it is slightly less complex, but I still strongly prefer a dedicated MRI of the abdomen to precisely define the exact cranial extent of that thrombus and its relationship to the hepatic vasculature, as this will guide the surgical approach. My formal recommendation is upfront radical nephrectomy combined with IVC thrombectomy performed by an experienced multidisciplinary urologic and vascular surgical team.
Okay, but the urologist specifically asked you about neoadjuvant radiation. In rectal cancer or sarcomas, we routinely give neoadjuvant radiation to shrink the tumor and make the surgery safer. Why not here? Wouldn't shrinking that thrombus make the surgery easier?
Here is the crucial board pivot. I would strongly reject routine neoadjuvant or adjuvant radiation for this patient.
Why is that?
While shrinking the tumor sounds theoretically appealing, radiation is simply not the standard of care for non-metastatic RCC with venous tumor thrombus. RCC is relatively radioresistant to conventional fractionation, meaning standard neoadjuvant doses will likely do very little to rapidly shrink that massive thrombus.
Right.
More importantly, embarking on a multi-week course of radiation delays the definitive curative surgery. During that delay, the thrombus could continue to propagate up the vena cava, turning a level 2 into a level 3 or level 4, drastically increasing the surgical morbidity.
Exactly. So what is the standard?
The standard of care is immediate surgery. Following his surgery, I would refer him to medical oncology to discuss adjuvant pembrolizumab, assuming his final surgical pathology confirms high-risk features, making him eligible for that systemic therapy.
Spot on. You avoided the trap beautifully and defended your rationale with solid surgical and radiobiological logic. The teaching pearl for the listener: recognize a surgical disease when you see one. Routine radiation therapy is not standard in this setting, and you must know your Mayo classifications to communicate effectively with urology.
Yeah, that's a key takeaway.
All right, take a breath. We are moving into Block 2. Oligoprogression on an otherwise effective systemic regimen. Here is your initial presentation and framing. You are seeing a 63-year-old man with known metastatic clear cell RCC.
Okay, metastatic clear cell.
Right. He has been on first-line nivolumab plus ipilimumab for 14 months. His known lung and liver metastases are stable or even slightly improved.
Good response, then.
Yes, but his latest restaging scans show that a single left adrenal metastasis has grown from 1.2 centimeters to 3 centimeters over the last 3 months. His ECOG performance status remains an excellent one. Medical oncology is sending him to you to ask about radiation. How do you frame this case?
I identify this strictly as oligoprogression. The key concept here is not just counting the number of lesions on a scan, but recognizing the biological behavior of the disease. He has a single site of acquired resistance in the setting of otherwise widespread systemic control.
Right. How do you visualize that strategy?
I like to use the analogy of a single leak in a mostly solid roof. The systemic therapy, the nivolumab and ipilimumab, is the roof. For 14 months, it has been keeping the rain out perfectly. His lung and liver metastases are stable.
Okay, I like that analogy.
But now the cancer has mutated or evolved in one specific location, the left adrenal gland. That is our single leak. You do not tear down the entire roof and build a new one just because of one leak.
So no switching drugs?
Exactly. Tearing down the roof would mean stopping the immunotherapy and switching to a second-line targeted agent, which might be more toxic and less effective for his overall disease burden. Instead, you patch the leak. In this case, the strategy is to utilize metastasis-directed local therapy to precisely ablate the escaping adrenal lesion. This patch allows us to preserve the ongoing benefit of the nivolumab and ipilimumab regimen for his stable lung and liver disease.
I like the roof analogy, but clinically, what is the underlying biology of this acquired resistance? Why does one adrenal metastasis suddenly wake up while the lung metastases stay dormant?
It comes down to clonal evolution and tumor heterogeneity. The original cancer was not made up of identical clones, it was a diverse population of cells. The immunotherapy successfully recognized and suppressed the vast majority of those clones in the lungs and the liver. However, over the course of 14 months, the cells in the left adrenal gland either acquired a new genetic mutation that allowed them to evade the immune system, or the local microenvironment of the adrenal gland itself provided a sanctuary site that shielded those specific cells from the immunotherapy.
And the radiation.
By using SBRT, we are mechanically eradicating that specific immune-resistant clone before it can spread further. Before I commit to a treatment plan, however, I require a formal, multidisciplinary tumor board review.
Good.
I want medical oncology and radiology to scrutinize the scans with me to absolutely confirm this is isolated progression and that we aren't missing subtle millimeter-level progression in the liver or lungs. Once isolated left adrenal oligoprogression is confirmed, I recommend adrenal SBRT.
Fantastic analogy, and the multidisciplinary step is exactly what examiners want to hear, the teaching pearl. Oligoprogression is fundamentally a management strategy question. The core issue you are solving is whether the systemic therapy is still working everywhere else. If it is, local therapy adds immense value. So what evidence supports this specific approach?
To justify this, I need to clearly differentiate the available trials based on the patient's systemic therapy status. First, I would mention the Tang Phase 2 trial.
Right.
This is a crucial study, but it specifically evaluated metastasis-directed radiotherapy for oligometastatic RCC in patients who were completely off active systemic therapy, showing we can delay the initiation of systemic drugs.
But this patient is on therapy.
Exactly. So for this patient who is actively on an ongoing systemic regimen and progressing, the Hannon and Chung prospective trials are the most directly relevant. These studies specifically looked at oligoprogression on ongoing systemic therapy. They demonstrated that SBRT directed at limited escaping sites can successfully extend the duration of the current systemic therapy line, achieving excellent local control with minimal toxicity.
And what about the Saber-Comet trial? I see residents cite that all the time for these cases.
I would briefly nod to the Saber-Comet Phase 2 trial as broad histology-agnostic support for the idea that metastasis-directed SABR improves overall survival and progression-free survival in oligometastatic cancer. But I would be extremely careful not to over-rely on Saber-Comet as my primary RCC-specific evidence. RCC was only a very small minority of the histology in that trial, which was heavily dominated by breast, lung, and prostate cancers. The Hannon and Chung data are the true bedrock for this specific RCC clinical scenario.
I am glad you made that distinction. Sharpening the evidence is exactly how you pass this board station. Tang is for the off-therapy population. Hannon and Chung are the cleanest, most precise references for this specific on-therapy oligoprogression scenario. Let us dig into the left adrenal SBRT planning. Walk me through the planning details, and while you do, tell me how you address this specific patient when he asks if the radiation is going to interfere with or perhaps synergize with his immunotherapy.
For simulation and planning, I would again utilize a 4D CT because the adrenal glands sit just superior to the kidneys and exhibit significant respiratory motion alongside the diaphragm.
Right.
I will fuse an arterial and venous phase contrast CT or a high-quality MRI to precisely delineate the adrenal mass from the normal functioning adrenal limb. The critical organs at risk for a left adrenal SBRT plan are the stomach, the splenic flexure of the colon, the tail of the pancreas, the small bowel, and the superior pole of the left kidney.
Okay, good.
Yeah.
And the fractionation.
Because this lesion has grown to 3 centimeters and is highly likely to be sitting directly adjacent to the stomach or the bowel, I will commit to a 5-fraction plan.
Let me challenge you on that. Why 5 fractions? In Fast Track 2, you defended a 3-fraction approach for a 4.5-centimeter kidney tumor. This adrenal tumor is smaller, only 3 centimeters. Why stretch it out to 5 fractions?
It is entirely about the surrounding anatomy and the concept of hollow viscous constraints. A left adrenal mass is frequently nestled right against the wall of the stomach or the splenic flexure of the colon.
True.
These are hollow, pressurized organs. If I try to deliver an ablative dose in 1 or 3 fractions, the dose per fraction hitting that stomach wall is extraordinarily high. The stomach mucosa simply cannot repair itself fast enough between such massive doses.
And what's the risk there?
The risk of creating a late gastrointestinal ulcer or a full-thickness perforation is unacceptably high. By spreading the total dose over 5 fractions, I lower the dose per fraction to a level that the hollow viscous tissue can tolerate and repair, while still achieving an ablative biological equivalent dose for the tumor.
Excellent safety-first approach. And regarding his immunotherapy, he read an article online about the abscopal effect. He thinks you're going to cure his liver mets by radiating his adrenal gland. What do you tell him?
Well, when discussing his immunotherapy, I will set very realistic expectations. I will clearly explain that the primary goal of the radiation is strict focal control of the escaping tumor. I will absolutely not oversell the concept of an abscopal effect or speculative immune synergy.
Why not?
While the abscopal effect, where radiating one tumor causes distant tumors to shrink due to an immune response, is a fascinating biological phenomenon, it is exceedingly rare and unpredictable in routine clinical practice. It is not something we can rely on or promise.
Right, we can't promise that.
I will tell him, the systemic drugs are doing their job everywhere else. The radiation is doing the job right here. Furthermore, I will coordinate directly with his medical oncologist regarding the timing of his infusions. Depending on the exact timing of his nivolumab and ipilimumab cycles and the normal tissue risk, we will make a joint decision on whether to briefly hold the immunotherapy during the week of SBRT or to continue it uninterrupted.
You navigated that perfectly. The teaching pearl here validates your 5-fraction choice. It is entirely driven by the hollow viscous geometry of the stomach and bowel. And regarding the patient counseling, examiners will actively set traps to see if you will oversell abscopal effects to sound cutting edge. You avoided it perfectly. The goal is local control.
Yeah, you have to be careful with that.
Definitely. Now let us pivot to a subcase twist. I am presenting a 58-year-old man. He presents with a brand new 5-centimeter right renal mass and 2 small lung nodules. A biopsy of the lung nodules confirms metastatic clear cell RCC.
Okay, so this is de novo.
Exactly. His IMDC risk score is favorable. His ECOG performance status is 0. He comes to your clinic. He has been reading online, and he wants local SBRT to the kidney and the 2 lung nodules so he can avoid systemic therapy entirely. He does not want the side effects of pills or infusions. Do you offer SBRT to everything?
I will push back carefully but firmly here. This is a very different clinical entity. This is de novo oligometastatic disease, meaning he is presenting with the primary tumor still in place, and synchronous metastases.
Right.
This is fundamentally different from metachronous oligometastatic disease occurring years after a nephrectomy. The established, standard first-line framework for de novo metastatic RCC remains systemic therapy. I will avoid promising him an SBRT-only pathway.
Why is de novo so different biologically? To a layman, they both just look like 3 spots on a scan. Why can't we just zap the 3 spots and be done with it?
It is all about the unseen micrometastatic burden. In metachronous disease, a patient had their primary tumor removed years ago. The systemic fire is mostly out, we just have a couple of embers to step on. But in de novo disease, the primary tumor is still intact and actively shedding millions of circulating tumor cells into the bloodstream every single day.
Good analogy.
The 2 lung nodules we see on the CT scan are just the vanguard. They are the largest, most established colonies, but we have to assume there are thousands of microscopic colonies developing elsewhere in the lungs, the liver, and the bones.
Right. It's systemic.
If we only use focal SBRT to treat what we can see, we are completely ignoring the massive systemic fire that is raging beneath the surface. I will explain that while we have tools to treat these spots, the biology of his disease suggests a systemic process that absolutely requires a systemic treatment backbone.
Very clear.
I would note that in highly selected cases, following rigorous multidisciplinary tumor board discussion, a pathway involving an upfront cytoreductive nephrectomy followed by complete metastasis-directed local therapy could theoretically be discussed, particularly for highly favorable low-volume disease. But I emphasize that systemic therapy is the standard, and I cannot allow the TANG trial, which evaluated patients off therapy, to be misapplied to justify an SBRT-only approach in a patient presenting with an intact primary and adenometastases.
That is exactly right. You held the line perfectly. The teaching pearl is critical. Do not overextend the TANG trial to de novo metastatic disease with the primary still in place. That is an entirely different biological risk profile.
Right, it's a trap.
You have navigated both blocks extremely well. We are now going to transition into the rapid review phase of the oral board. This is meant to test your immediate recall and ensure you haven't fallen for common cognitive errors. I'm going to strictly list 3 traps and then 5 pearls, and then we will move into a rapid-fire board blitz. First, the traps. Trap 1, offering neoadjuvant radiation therapy for an IVC thrombus.
Right. Do not do it. It is a surgical disease, and delaying surgery allows the thrombus to propagate.
Exactly. Trap 2, calling RCC purely radioresistant and refusing to offer SBRT for a medically inoperable primary tumor.
Right. That is an outdated mindset that denies the patient a highly effective nephron-sparing option utilizing high doses per fraction.
Excellent. Trap 3, over-applying the TANG trial to modern immunotherapy oligoprogression scenarios.
TANG is for patients off therapy. Use Hannon and Chung for patients actively progressing on systemic therapy.
Spot on. Now, for the board pearls, I will list exactly 5. Pearl 1, fast-track Zucity is your standard. 26 gray in 1 fraction for tumors 4 centimeters or smaller. 42 gray in 3 fractions for tumors larger than 4 to 10 centimeters.
Got it.
Pearl 2. For solitary kidney planning, the absolute critical step is to contour the uninvolved ipsilateral kidney minus the ITV using Boolean subtraction and strictly protect that remaining volume.
Boolean subtraction, crucial.
Pearl 3. For venous tumor thrombus, MRI is the preferred imaging modality to define cranial extent, and surgery is the standard of care.
Yes, surgery is standard.
Pearl 4. Adjuvant pembrolizumab, not radiation therapy, is the standard discussion post-nephrectomy for high-risk patients.
Medical oncology referral.
In Pearl 5, TANG is for off therapy. Hannon and Chung are for on-therapy oligoprogression. All right, doctor. It is time for the board blitz. I'm going to ask 3 rapid-fire questions, and I want a concise, 1-sentence answer for each. Question 1. You have a medically inoperable patient with a 3.2 centimeter solitary kidney mass that is located precariously near the small bowel. What is your precise prescription?
I will prescribe 42 gray in 3 fractions to prioritize bowel safety over single fraction convenience.
Excellent. Question 2. A fit, healthy patient presents with a clear cell RCC and a male level 3 IVC thrombus extending above the hepatic veins. What is your next step?
I will refer the patient for an upfront radical nephrectomy with IVC thrombectomy.
Perfect. Question 3. Your patient has isolated adrenal oligoprogression while on a highly effective immune checkpoint inhibitor regimen for the past year. What is your next step?
I recommend adrenal SBRT closely coordinated with medical oncology, followed by short-interval CT restaging.
Outstanding work. Let us summarize today's session. The overarching lesson is that RCC mock orals are fundamentally tests of clinical judgment and boundaries.
Yeah.
If you have a medically inoperable primary kidney tumor, SBRT is a profoundly strong, evidence-based answer utilizing precise radiobiology.
Definitely.
If you are dealing with a non-metastatic IVC thrombus, surgery is the indisputable standard answer. And in cases of carefully selected oligoprogression, metastasis-directed local therapy is the perfect tool to patch the leak and preserve an otherwise effective systemic line. You handle the nuances of fractionation, contouring, Boolean logic, and patient counseling exceptionally well.
Thank you.
Next episode, we will be shifting gears to cover upper tract urothelial carcinoma. Complete practice oral boards at radonsmartlearn.com and subscribe to Rad Onc Smart Review for our next episode. Thanks for tuning in.